Good evening, everybody. If you're like me, you've just got back home from work, so we might be a bit slow in getting started. But welcome to this 14 Fish Facebook live streaming, and it's an update on the CSA. For anyone who's sitting the CSA in 2018, this is all about what to expect and some quick tips on how best to deal with them. So my name is Mark Coombe, and I'm a working GP and I'm a current CSA examiner. I've spent a lot of time studying why candidates pass and fail the exam, and so I've helped thousands of candidates pass the CSA. Recently, I've created the Pass the AKT and Pass the CSA packages with 14 Fish, and so there will be a number of you watching this evening who have already passed the AKT with us, and so you'll know that this methodology works. Tonight, I plan to give you a brief update on the CSA, and then I'll answer any questions. We've already had a number of questions through, so thanks for everybody who's done that. And you've met Liz before, so this is Liz, who's here to sort of pick up all the questions as we go along, and so you'll see a bit more of her in a minute. So if you're sitting the CSA in 2018, whatever you do, don't sit the CSA without going to the RCGP website. If you don't know how to find it, just Google CSA and RCGP, and what you'll find on there is avoid the ads, obviously, but if you go down below the ads part, you'll go straight onto the RCGP CSA page, and there's lots of details on there on when to apply, how to apply, and lots of great tips and stuff. And there's videos about the exam centre, so it's definitely worth having a look at. So what is the CSA? I've been thinking a lot about this over the last couple of days, and to a certain extent, I think it should probably be called the CSA, because when we first started 10 years ago, so the CSA started in 2007. When we first started, it was very much weighted to being just a communication skills assessment, but now it really is a mixture of communication and clinical skills, and I think that's where people, if you're sitting the exam, you need to aim for. So it's a clinical skills assessment, and there are currently 13 cases, and they're done in a surgery split into 7 cases followed by 6, and they are by and large made up of a mixture of the sort of typical cases that you're going to see in general practice. So although there are the odd case like a telephone consultation or a third-party consultation, somebody coming in to talk to you about their mum or whatever, then the vast majority are really just a patient coming into the consulting room with you and presenting with a typical medical problem like a headache or low mood or whatever. Okay, so the patients are all played by very highly trained role-playing actors. We've done lots of research on the exam looking at how realistic candidates feel that the actors are, and you know, over 95% of every dart that we've ever done where we've tested this, then the candidates have really felt that the patients were very realistic. And I think one of my key tips to you would be to really put yourself in it as if they are live patients, and so deal with them and speak to them as if you would a live patient. So you've got to believe in the situation and buy into what we're trying to do. You're going to be assessed, so the patients, when the buzzer goes, there's a knock on the door, the patient comes in through the door, then they're going to be accompanied by at least one assessor. And you don't need to worry about that. Unlike in undergraduate exams, unlike in early exams, you would interact with the examiner, whereas in the CSA, we really don't want you to interact with the examiner at all. So go in with the view that you're not going to speak or interact with them at all. The notes for your patient are on iPads, and I think 10 years ago some people didn't have iPads, but pretty much everybody has got some sort of tablet, and so you'll be used to the sort of movement of the screens backwards and forwards, and all the time there is someone monitoring what you're doing. So if you start logging yourself out or going onto the wrong patient's notes, we'll tell you. What about making notes? So in comes the patient, in comes the examiner. They give you, deliver you a fixed line, you know, good morning, doctor. I've had a headache for the last week, whatever it might be. What about making notes? Well, you can make notes if you like. There is a laminated sheet and there is a felt tip pen. And at the end of each case, you can clear the laminated sheet. Really, I would encourage you not to make notes through the exam, not to make notes when you're talking to the patient. But it's certainly, if a patient says something in the middle of a conversation that you think you need to pick up on a later date. Let's say, for example, you know, I've had a headache and my wife thought I was quite stressed. You might be asking about the headache and just jot down, you know, why I felt stressed, so that you come back and ask about why the wife thought the patient might be stressed. So you don't need to make notes, but just use it as tips. And as soon as the consultation is finished, a buzzer will go. And as soon as that buzzer goes, the exams, that consultation is finished, and you can't score any more points. So sometimes candidates think, as the buzzer goes, it's a really good opportunity to sort of ask about their flu jab and their smear, and you know if they want to be followed up. But once the buzzer's gone, there's no more scoring. So you really need to make sure that you've done your full consultation in the 10 minutes. With that in mind, you therefore need to practice consulting in 10 minutes. And I know some of you, your partners or the doctors in your practice may be consulting at 15, because that's not what the majority of people are doing in UK general practice at the moment. Then it's still 10. So you really must practice at 10, and you must practice consulting in that 10-minute period, so that you've got your whole sort of consultation clock is not concentrating on the actual physical clock, but it's concentrating on you knowing where you are in the consultation, roughly when you've reached 3 or 4 minutes, 5 minutes, 6 minutes. You know at 8 minutes you need to start wrapping up the consultation and start managing the case. So all of the cases, no matter what they are, whether it's a depression or a tired all the time, or you know, someone with backache, they're all marked in 3 very specific domains. And those domains are data gathering, interpersonal skills, and clinical management. All domains are marked out of 3, so every case has a maximum score of 9. So it's really, really important that you score in each domain in every case. That's absolutely vital. So you've got 13 cases with a maximum score of 9. Mathematicians amongst you will know that that's 117 maximum score. And some people have scored, you know, really well in the CSA, well over 110. So it is possible to score a maximum of 117. To pass, you really need to score 75 or over on a very difficult day. So the pass mark does vary on a day-to-day basis, because obviously some groups of cases, so some groups of 13 cases are harder than others. And so on those days where the case facility is harder, then the pass mark will be a little bit lower. But it's only going to vary by a few points, and certainly you know, the lowest you could hope to get to pass would be 71, 72. So let's talk a little bit more in detail about data gathering. This isn't data gathering as you would do as an SHO in A&E. This is a very targeted UK general practice history, and so it needs to be guided by the patient, and it needs to be based on a structure. And for those of you who missed the last Facebook Live, which was about a month ago, I talked in detail about the consulting and communication skills that help with this. So do go onto our Facebook page and have a look at how I explained it, or obviously come and join us on the Pass the CSA package at 14 Fish. So data gathering is a focused interview. It's about taking a sufficient history to reach some form of sensible diagnosis, and you've got to exclude serious illness. So you need to be able to know your red flags. And if you don't know your red flags, then practice them with your colleagues, or in fact get a book like Symptom Sorter, which will talk about them, various major presentations, and how you can ask questions to sort out or exclude any serious illness. Once you've done that, then you should be planning, if it's appropriate, to do a physical or mental examination. And you should really be doing that right in the middle of the consultation at about 5 minutes. And so you should go at a physical examination as if in the same way that you would in your surgery. Some people are a bit worried about the level of examination. There's some really quite useful, there's arthritis.co.uk shows some very, very good joint examination, and there's some very good e-modules on the RCGP website. Somebody emailed me just a couple of days ago because they couldn't find them, and so we put that link on our website. If you want to have a look, it'll take you straight into the RCGP page where the e-learning is. The other thing about data gathering that you need to be aware is that you need to have gathered information from the notes. So you need to give yourself enough time, excuse me, you need to give yourself enough time at the beginning of the consultation to make sure that you read the notes. So when the case finishes, there's about a 2-minute gap between then and the next case starting. You can't do anything with the old case that you've just done. So you've just got to leave it and move on to the next case, and use those 2 minutes to make sure that you know what's coming through the door. And it will give you a good idea as to what your demeanor should be and so on. So if you're breaking bad news, sort of greeting somebody with sort of jazz hands and sort of going, hello, isn't going to be the right way to do it. So make sure that you look at those. Just like in normal surgery, if you have a bad case, and you know, there are some difficult cases on the CSA, if you have a bad case, you've just got to leave it behind. You can't continue worrying about it and thinking about it through the next set of cases, because it will just affect your mark. So clinical management is the next domain, and clinical management is the commonest cause of failure in the UK, both in UK trained and non-UK trained graduates. And that really happens for 2 reasons. The first thing is often after having done the AKT in ST2 and then doing the CSA in ST3, particularly in people who've had gaps for whatever reason that might be. I mean, it might be a maternity leave. Then there's been a reduction in clinical knowledge, and so part of the CSA package that we offer is continued use of the library clinical updates. So you must make sure that you're really up to speed with the latest guidelines and the latest management, and you will be marked on that. The other reason for failing in clinical management is just not getting there. So if you don't get the clinical management within 10 minutes, the examiners will only be marking you out of the first 2 domains, and so you'll only be marked out of 6, which then makes the passing the exam extremely difficult. Other things in clinical management is offering effective and safe treatment, using investigations, prescriptions, and referrals appropriate, and you only need to do, you would only need to talk through those in the vast majority of cases. There are a couple of cases out of the whole bank in which you would be expected to write a prescription, but the role player will then encourage you to do it and sort of say, really, doctor, I would like you to write a prescription. And if the role player keeps saying that, don't ignore them. You need to recognize that some of the cases are routine. So somebody with mechanical back pain, and some are urgent. So you might have someone with acute coronary syndrome, in which case you'll be expecting to admit them to hospital. And so if you would normally admit a patient to hospital, use the 10 minutes to score in your 3 domains, but make sure in your management you express that you understand, you know, that you have genuine concern that this case needs to be dealt with urgently, and that you'll do that appropriately, whether that be getting them taken to A&E or arranging an admission, or actually even calling an ambulance if they had acute coronary syndrome. You need to manage risk and comorbidity. You need to encourage health promotion, but only really where it's appropriate. You know, somebody comes in who's just been badly bereaved, and sort of giving them a big lecture on not smoking or not drinking is, you know, would be a waste of your time, because health promotion would only be appropriate in a case perhaps where it's you know, primary prevention of coronary heart disease or somebody with diabetes. And you need, within the 10 minutes, your last statement really should be arranging follow-up. So you know, you presented with this, we've agreed a management plan, and I think, you know, it would be appropriate to review you within a couple of weeks, unless things obviously change, and you might then want to state the sort of things that might make you want to review them earlier. Interpersonal skills is all about you being on your top game, you showing rapport, you know, you genuinely listening to the patient. And this is why you need to know your structure for the exam. If you don't know your structure, so you're thinking about what's next, you're not familiar with where you are in the consultation, because there's a definite beginning, a middle and an end. And equally then, you're watching the clock, and you know, it becomes apparent that you're not really listening. And one of the biggest things in the CSA is that you must listen. So you ask a question, you must listen to the response and respond. So exploring the patient's concerns, everyone gets a bit bored with ideas, concerns and expectations, but it really is a great skill, and you need to learn how to ask it in a way that's appropriate for your style. And we talk about a lot about that in one of the other Facebook Live videos. I said you need to listen, but you also need to use appropriate language. So, you know, if a patient wants something explained much more simply, then you need to be able to do that. You should also negotiate treatment options, so give patients choice. But, you know, we now don't want you just to give random choice. You know, somebody comes in with a bad knee and you just sort of list, you know, we could give you physio or painkillers or x-rays or refer you or whatever. We don't want random lists. You know, we want the patients to feel that, you know, all of the time that you've spent as a doctor, you know, the 10 years that you've spent in medicine, you can actually give a valid opinion. And so you would say, well, you know, this is my advice. There are some options that are perfectly reasonable, and I would advise this. And you know, I think a lot of you would say that, particularly over the next few months, we're going to see a lot of patients in the surgery who've got sore throats, and finding out whether they think antibiotics would help early on, then in the consultation, then helps you explain, you know, whether or not you feel antibiotics would be appropriate, and then negotiating together to come some sort of management plan, and that may be no antibiotics or a delayed script, or actually giving it if you know, thought the patient had scarlet fever, for example. Okay, so why do candidates fail the exam? Well, the first thing is that they have no structure. And so if you look at the model that we use at 14 Fish, then we very much describe that the consultation has a series of stages. So there are 3 main stages in the consultation. In each stage, there are a couple of tasks for you to do. And so watching somebody who's got really familiar with that, they move seamlessly from one task to another, from first stage to second stage, and then through to the end. Now, when a consultation becomes a bit disorganized, then you often watch the candidates going from task 1 to task 2 and then back again. And there's often this sort of circular motion. And so it's important to learn the structure to the consultation without being mechanistic. So if you just ask the questions without listening, so you say, well, actually, I did the structure that Mark told me, and I said, you know, what are your ideas, concerns and expectations, and who's at home with you, and how's that affecting your work? And I'm going to ask you some questions about, you know, excluding serious illness. You've got to do it with feeling, and you've got to do it with listening, and you've got to respond to what's said so that it flows nicely. But then equally, you mustn't keep jumping backwards and forwards. Failing to involve the consultation. We often talk in consultations about there being 2 people asking questions. So you've got this interaction between the doctor and the patient all the way through the consultation. And in a dysfunctional consultation, and I had one this afternoon, I was asking the patient something and they obviously wanted to tell me something different. So suddenly we were separated, and I had to sort of say, I'm sorry, but I've lost track here. And you know, there's obviously something that you want to tell me. And actually what it did was it brought us back together, and we then carried on the consultation in a much more sort of functional way. One of the complaints that we get from the role players is that failing candidates often lack empathy. And some people have questioned whether you can show empathy in an exam like this. And absolutely you can. If you believe that that role player is a patient and they're telling you something that's very sad or emotional, then as a GP you should genuinely be interested. And so I don't think showing empathy in a role play situation is particularly difficult. And in fact, if you don't show it in a role play consultation, you almost certainly don't do it in your own surgery. So other things that cause failure is lacking to, unable to answer directed questions, so unable to get to the bottom of what the problem might be, poor timekeeping, which results in one sort of going round and the consultation looks disorganized, but really not getting to the end, so you don't clinically manage. And this really important thing now that we're looking at clinical skills as well as consulting skills, and that is that you need to keep your clinical knowledge at a decent level. So why do candidates pass, which is a much more positive way of looking at things, but you can learn things from both passing and failing candidates. But your passing candidates often have trainers that are willing to really get in to understand what it is that you need to do to pass the exam. And so your trainers don't just collude and say, well, that was really good and, you know, well done and all that sort of stuff. You know, when you're first consulting, a bit like playing an instrument, when you first start consulting as a GP, you know, you should be rubbish at it. I'm sure that I was completely rubbish at it. So don't be scared of being rubbish, but equally then you've got to learn. You can't just go in, having worked in a hospital for years, and start consulting like a brilliant GP. I think it probably took me a couple of years to learn how to consult properly. So your trainer should be saying to you, you know, there are other ways to do it, or these are other ways, other questions that you could ask, or teaching you how to ask it with a bit more feeling, or in a way that the patients will respond. So really important that your trainers are aware and don't collude. I met some brilliant trainers up in Health Education Northwest on Wednesday, and they were fantastic. It really was great to see such a positive group who had so much to say in a positive way about their training experience. So you need to adopt a good consultation structure as early as you can. Now, my registrars, trainees, you know, they are adopting the structure from ST2, and they're down to 10-minute consulting really very quickly by ST3. Equally, your case mix is important. So the CSA, you're not going to review lots of patients that you've seen over your period as a registrar. So it's important that a good chunk of your surgery for a month or so before the exam is on the day bookable patients, because they're much more like the CSA. So you need to get down to 10 minutes, as I've said. You need good clinical knowledge, and that's, you know, we watched some brilliant consulting by some very clearly passing candidates, and they know exactly what they're dealing with, and they manage common conditions well. You don't need to be afraid. I think the passing candidates talk a lot about videoing, and certainly my registrars and trainees are videoing really every week until they're very, very clear what they're doing. And if you don't like video, sitting in or even audioing some consultations is really quite valuable. You must practice in your group, so get your peers to do mock CSAs and to show you their videos from their practices, because you learn so much from your peers. I watch thousands of consultations every year, and I still come away learning a nice new phrase or a different way of doing things. And so you can learn something all the time, and hopefully you'll keep learning about consulting for the rest of your career. The other thing is a lot of your training program directors are absolutely excellent. There's some brilliant programs where I am, but you really must persuade them. They'll be keen to ask you what you want out of the training program year for your ST3. And it's very tempting, because you come from a background in hospital medicine, to ask for, you know, clinical updates rheumatology and get the consultant dermatologist to come and talk about dermatoscopes and things like that. I really would strongly encourage you not to do that. If you want to do that, make a personal arrangement, go to the clinic yourself. What you should be practicing is learning how to master the 10-minute consultation, which in UK general practice is the key to being a good GP. So everything that you need to know on how to pass the CSA is on our 14 Fish Pass the CSA package. Please do work with your trainers and your program directors. We've added an extra utility on the package so that if you consent, your trainers can come in and look and see what you're doing and help you, and you can watch consultations that we've done on there with lots of different styles, and they can watch it with you just to sort of make you really understand what's needed to pass the CSA. And it really doesn't matter who you are or where you learned, but if you focus your learning and know what you're doing, then you will pass the CSA. So don't feel that anybody out there cannot pass the CSA. I'm absolutely sure you all can. And so I'd like to wrap up what I'm saying, because otherwise I'll be going on way too long. But just to sort of say good luck to anybody who's sitting the exam in 2018. Don't forget to look on our Facebook page at some of the other videos that we've done. Our next live Facebook will almost certainly be in the first few months or the first couple of months of 2018. So if there's anything that you want me to cover or any specific questions or areas you want me to talk about, then let us know. We're very, very happy to help in any way we can. So I better bring Liz back in and see if anybody is not died of boredom and would like to ask some questions.
Hi there.
It's a bit like morning television now, Liz. I think this was Phil's idea, wasn't it?
Well, it was a shared idea.
Oh, okay. Well, thanks, Phil, for that.
We do have some questions that people sent in. So one of the first ones is, if I examine a patient, how will I find out the examination findings, and what if they are normal? Okay,
that's a really good question, because as I've said, there are no real patients in the exam. So the role players playing the patients will not have any clinical findings. However, if you don't examine the patient properly and the case has got positive findings, then you won't get them. So you must make sure, so for example, on your chest examination, you must make sure that your stethoscope is on the chest and you wait for them to breathe in and out at the various places. So if somebody came in with chest pain, for example, and you just pop your stethoscope right in the middle of the chest and just say, oh, that sounds okay, you're not going to get the clinical findings. So you must examine people properly. And those two links that we've got on the website, the RCGP e-learning module and the arthritis.co.uk joint examination, really, really important. So yeah, you must examine properly. And normally either the examiner will vocalize the findings, which might be take the examination findings as you find them, which will mean that they're normal, or it might say that there are crackles on the right base and they've got a high temperature and so on. So so just make sure you do your examination properly.
I just want to say to Matthew that we will put links to the RCGP physical exam videos. We'll send them to you privately, as well as putting them a bit more obviously on the website for you. Sorry you can't find them.
Yeah, no problem. They are quite difficult to find, actually, so don't worry. We can send those to anybody that wants them.
Another question is, what sorts of notes should I make in the exam?
Yeah, I mean, I covered that a little bit. So you've got a laminated sheet in front of you in the exam, and you can write down what you want. But if you're writing too much, you're looking down and you're not looking at the patient, which is what we want you to do. Look and listen, because they will give you verbal as well as non-verbal clues. So don't forget to that. So I would just write down anything that you might forget. Sort of, you are going to be a bit anxious on the day. I mean, I remember my exam, I was very anxious, but just jot down, if somebody mentions something, where they work, or, that one of their family members was worried, you might want to say, once you finish that particular dialogue or conversation, you might want to say, you mentioned that they were worried. What were they worried about?
I've just got a question here from someone on Facebook, Ban. Hi there. He says there was a question earlier. I think it was he's referring to the question on the events page that you had a quick look at, and he said on the post a non-British trainee is struggling to pass the exam, what advice would you give them?
Yeah, so we've actually done some videos for trainers that are on our website, which goes through where international medical graduates tend to fall down. So please do have a look at that video. It's about 10 minutes long. So there is some detail on there about specific issues with international medical graduates. But by and large, just because a lot of training in other countries is very disease-based, and so one of my partners is from Iraq, and he failed the CSA first time, but actually with a bit of tuition, he did incredibly well. So he went from 55 to 95 in one sitting, and is a brilliant GP. But he just needed to learn how to consult as a UK GP, which is much more illness behaviour based. If you want to learn about illness behaviour, it's on the previous Facebook video. But yeah, so the predominant thing is really being a bit disease focused, a bit doctor centered, and possibly not thinking about the ideas, concerns and expectations and psychosocial bits at the beginning of the consultation. So you need to pick all that sort of stuff up so that you can use it in the explanation at the end. But have a look at the last Facebook video live, and have a look at the video for trainers, which is on our website.
Hi to Harris, just to say that all the videos that Mark's referred to, so like the previous Facebook videos, are all on our Facebook page. If you did want to have a look at the CSA or the CSA and SOX packages, they're all on our website. So just Google 14 Fish and we'll be at the top, and you'll be able to see all of the packages on there, and it'll give you more information. Moving on to some more questions. We've got a question here. It says, a friend scored less than I did in the last exam and they passed and I failed. Why is that? Okay.
As I mentioned, the CSA, your CSA, will be 13 cases. And those cases are made just like a recipe. They're made up to a very specific design. So there's, a few emotional challenge, some physical examination, some mental health, an elderly, so someone over the age of 65. So there is a very specific recipe, but even though we make that recipe very specific, there is still a variability in how people deal with certain cases. And so if you have if your 13 cases are quite hard or a bit harder than your colleague, then the pass mark will be lower. So the pass mark goes up if your collection of cases is easier. So it doesn't vary hugely because we really do look at the cases in some detail, but it does vary a little bit.
And we've just got a question here from Nikki. She's asking roughly what proportion of cases are likely to be obscure presentation that you rarely see in practice.
Okay, so the idea of whenever you do it, whenever you set an exam, and I was right there at the beginning in 2007, and I was part of the case management group that wrote all the cases, I absolutely want to guarantee you that all of the cases are doable by a UK or international medical graduate trainee at your level. That's what they're designed for. There are a few cases like genetics cases, which we all find difficult. And if you look at the CSA package, you'll see that we cover those in some detail, and we look at some of the more difficult sort of problems that you might get, so that you're fully prepared and able to do it. But yeah, so it may feel, because whenever you come out of exam, you don't remember that you saw someone with a cough and a cold, someone with eczema, someone with low mood. What you do remember is that you saw someone with Huntington's chorea, and so or that your friend told you that they had a case of Huntington's chorea or whatever. So the internet is full of people giving examples of what seem like very obscure cases, but they're obscure cases, and we want you to, the small number of obscure cases are really there just for you to show us that you can communicate in such a circumstance. And so sort of finding out the background, finding out their psychosocial, doing an appropriate examination, explaining that you don't deal with this sort of case, and excuse yourself for your ignorance. I saw a case at the end of last week of a completely blind person, I hadn't seen a blind case for years. And so I sort of had to say, I'm really sorry. I don't know whether you want me to take your hand or whether I should lead you to your seat. And I wasn't quite sure how to deal with their dog, because I know that working animals you shouldn't treat like a normal pet. So all I had to do was explain all that and find out the best way to communicate with them, and then find out what they wanted and how I could possibly help, and listen. And when you don't know what to do, ask. And if you do that in the exam, even if you knew nothing about the presenting complaint, you're likely to score really well. You know, you may not score 9, but you might well score 8. So don't worry about obscure things. They're not testing your clinical knowledge about that. They're testing your communication skills.
It's nice. We've got more questions here. So one is, why don't they use patients with fixed physical signs in the exam?
Okay, that's a really good question. Because PACES and the OBS and Gynae exams do use cases with fixed clinical signs. We run 3 floors of 13 cases at the same time, and so it's quite difficult to get 3 people with exactly the same clinical signs. We also do the case 26 times in a day, and we found that patients get extremely bored after a few cases, and so after about 5 times of playing the patient, then they often go off script and start to go off piste, and as a result, it gives an unfair an unreliable go for the candidate. So it's really to make sure the exam is as reliable as possible. You know, it may be that we use mannequins with fixed clinical signs in the future, but we're certainly not doing that in 2018.
So we've just got a new question here from Matthew on Facebook. Are we expected to know the exact timeframes for every major illness with regards to DVLA or fitness to fly? No,
I mean, that's the sort of thing. I think, so in the AKT, you will need to know the big topics on the DVLA, because they're easy to ask questions and they're right and wrong about epilepsy, post-MI, when you can drive. But when you get into real practice, you know, sometimes you do have to look stuff up in the BNF, or sometimes you just need to explain that you don't know and you'll need to look it up, or actually just encourage them to contact the DVLA and explain the situation, write down their clinical problem so that they can talk to the DVLA themselves. So we don't want you to be complete sort of gurus of everything for your CSA. I mean, know the big topics, the sort of level that you knew, you know, sort of stroke and MI for DVLA, but you know, there is going to be stuff that you don't know, and you might have forgotten the dose of a drug and that sort of stuff. Don't worry about that. Explain that you're going to look it up and be safe. Don't just guess.
We've got another question. So how can I speed up my consultation? I always overrun.
This is such a common problem, and a lot of people get to the exam being able to consult at 12 minutes, and that's not really good enough. The best way to improve the speed in which you consult is to understand the structure that we use. So understand the way that we're explaining it, that there's a beginning, a middle, and an end, and what tasks you need to do in those points. And then really you view the consultation as a one-way street. You do each task in full, and then you move on. And you'll just find that the flow's much better. I think it's when you're a bit disorganized and you tend to start thinking, oh, have I forgotten something? And then you ask the same question again. So I watch a lot of videos of people consulting, and quite often they repeat themselves on a number of occasions. So speeding up is just getting very familiar with your structure and getting a bit more confident, so you don't keep going back on yourself. And then you'll find equally then the patient doesn't want to bring you back all the time because they think you've missed something. So get your structure, learn it fluently, and you know, give of yourself. So make sure that you're using your terminology, you feel comfortable, and you know where you are in the 10 minutes, and you will be able to consult 10 minutes, I promise.
Thank you everyone for your questions, by the way. We've got another one here. Are we marked down in exams if we ask for examination when it's not needed? No, so there's no, general practice is quite heterogeneous, so it's a mix of lots of different things, and so there isn't one thing that you can say or do in a consultation
that will make you fail, because you're marked on a whole load of different things. And if you ask for the examination findings and the examiner isn't expecting to communicate with you, they will do something to cut that conversation short. So they'll say, take the examination findings as you found them, or the examination finding is normal. But you certainly wouldn't be marked down. If you are asking the examiner when it's not part of the consultation, it probably means that the consultation is going wrong. It probably means that you haven't gained that information that I talked about in the first half of the consultation. So if that is happening to you, or has happened to you, you just need to think a bit more about how you're consulting and practice.
A common question we get is there a surprise consultation at the end, like a 14th consultation? Yeah, so
we did pilot a 14th case in 2017, and it's likely that at certain points in 2018 there will be a pilot case. The pilot case in 2017 was a written case which was around complexity of prescribing, so rationalizing a prescription for a nursing home. But I really want you to be reassured that it is a pilot case. It's really for us to look at the exam to see if we can make the exam more reliable. If it's something that adds to the exam, then in 2019, 2020, at some point in the future, we might add it in. But if you're sitting the exam in 2018, you are not going to get a case that will count above the 13 cases that I've described already. So don't worry about that. And we can't suddenly, we have to go to the General Medical Council to add in new cases, and the General Medical Council take about a year to look at the evidence that we produce. So you're definitely not going to get a surprise case in 2018 that will count. I hope that's clear.
I hope that's put some people's minds at rest. Is it worth doing role-playing groups?
Yeah, 100%. It's good because when you have a group of people, and there has been debate as to what should be the size of the group, and I think it's probably a minimum of 4 or 5 and a maximum of 8 or 9. I think any bigger than that, I mean, ideally a small group should be 6. And picking out the cases that you found difficult in surgery. So whether you record it electronically or just on a pad, make sure that you write down the cases. You know, somebody comes in asking for something a bit odd, or there's an ethical dilemma, or somebody came in and you found it difficult to explain what AF was, or a TIA. Then bring it back to your group and role play it, and try lots of different ways. The only thing about being a group is, don't be too critical on each other. What you're trying to do is not tell everyone they're great, but facilitate improvement. So you say, okay, this was where that role play went, and what could we do to score even better? And so definitely practice in groups if you possibly can, and do it in your day release if your training program directors will facilitate that.
So we've got some questions here that might make more sense to you in a GP way. Do we fail a case if we don't know anything about a presentation but we play safe?
Yeah, so this is a licensing exam for UK general practice, and so if you genuinely don't know how to manage a case, then you need to get some advice, or put the patient in a holding position such that you can find out from somebody. I mean, obviously in UK independent practice, you're going to be marked. You're not going to gain a lot of marks if you're continually saying, I need to speak to my trainer, or I'm not sure whether this is a case of angina, but I'm going to refer you to the hospital. Independent general practice is not about you having massive uncertainty about big areas in UK general practice. So, you need to keep really up there with your clinical updates, and we're not going to give you a whole load of stuff that you don't know. It's going to be all of those stuff that you've seen in our clinical library. That's the things that are going to come up in the exam.
Okay, if you've got any questions, please do leave them in the comments. I think we'll probably be wrapping this up soon because we're coming on to an hour now.
Oh dear.
45 minutes so far.
Three people have died of boredom.
Well, they're all still watching, so that's a good thing.
Oh, that's good.
Another question we get is, do you need to write any prescriptions in the exam?
Yeah, so I did mention it earlier on, but you don't need to write prescriptions in the vast majority of cases. Just vocalizing what you would give and how many times to take it to the patient is absolutely fine. There is a couple of cases about safety around prescribing, and that's usually around controlled drugs. And so it might be that, you know, one of the biggest problems or one of the biggest complaints about GPs to the General Medical Council is errors in prescribing. So it would be perfectly reasonable in an exam about UK general practice to see that you can prescribe safely. So if the role player insists, particularly about controlled drugs, that you write a prescription, then go ahead and do it. But by and large, you know, 95% of cases you could just get away by verbalizing it. But take your cue from the role player. You know, if they're insistent about something, I would like you to examine me, for example. You know, I'd like you to write me a prescription. I'd like you to tell me what's in the leaflet you've just given me. Then, you know, what they're doing is trying to help you score some points by getting you to do a task that's got some marks associated with it.
Perfect. I've got a few other questions. One of the questions we get sometimes is, what is the best way of sharing management with patients? So
I think, as I said a bit earlier, then what we don't want you to do is just come up with a list of potential management options and then go through them and then get the patient to choose. What we really want is for you to guide the patients, but to say, look, you know, I mean, for example, I'm not particularly keen on taking tablets, whereas some patients want, you know, a pill for every ill, as it's called. And so I would say, well, you know, having examined your back, I'm almost certain it's soft tissue. I don't think there's anything significant going on. It will almost settle by itself. And so actually one of the options is to do nothing and just let it get better. You know, if that pain is getting in, you know, interfering with your function every day, stopping you going to work, then, you know, we could consider some painkillers. You know, what do you think? So don't force the management options. And, you know, if someone's got, you know, acute coronary syndrome, you know, you need to say that I'm really worried that this pain that you're getting in your chest is your heart, and I really want you to go down to hospital. I mean, obviously I can't force you. You can't force your patients to do anything. Their patients have their own autonomy. But by and large, if you explain exactly why you're worried, then the patient will do it. So it's not a matter of just giving just a big list of options. It's a matter of giving sensible professional advice. You know, that's what we want you to be, independent professional GPs.
I've got a question here from Hassan. If we attend a GP update course, are we expected to know the latest medication, referral pathways, or should we stick to NICE guidance for the CSA?
Okay, that's really good. So what we've done, GP update is, in my view, by far the best of all the summaries of all the latest evidence, and it's really good if you've got time to go through all that. What we've done at 14 Fish in the major topic areas, which are the ones that will be covered in the CSA, is summarise the latest acceptable guidance from NICE and SIGN. And where there isn't guidance, giving guidance on that. So you know, in a 20-minute video, you'll be able to see exactly what's there. I mean, if you had to make one thing, what would I say? I think you need to be aware of NICE guidance. It is only NICE guidance. It is only guidance, so you don't have to stick to it 100%. But I think you need to give what will be acceptable in UK general practice. So you need to be up to date enough.
Cool. I've got a few more questions. So Brian's got another question. He's asking, so he's saying, in our day-to-day surgery is practicing cases, but what is minimum time you would recommend for exam preparation? Okay.
I mean, personally, what I've always done with my trainees is I get them started right at the beginning of ST2. So when they sit the exam, whether that be in the beginning of ST3 or later on, depending on their life circumstances, they actually just don't find the exam any different from normal. What's the minimum preparation time? I reckon I could get somebody, if they really followed exactly what I was encouraging them to do, 2 to 3 months.
That's a quick timeline.
But I would really be hoping. So certainly with my current partner, who I helped as a registrar, they've sort of, you've got to make a life change. You've got to make a life decision, and it's really quite difficult. It's like losing weight, for example. You know, some people can crash course and lose a lot of weight, but often they put it back on. You know, if you crash course into the CSA, then often you go back to bad habits and bad consulting when you're finished, and that makes life as a GP really miserable. So I wouldn't look on it as just preparing for the CSA. I want you to sort of understand that it really will help you as a GP. Not all the time, but if you've got those skills, you really will make it will make your life a lot easier.
I've got another question from Harris, and sorry if I get this wrong, Harris, but I think you're asking, can you score 0 in any of the any of the domains in the CSA?
Yeah, you can. So it's marked out of 3, and then a clear pass is a 3, a pass is a 2, a fail is a 1, and a clear fail is a 0. So yes, you could actually score 0 in a whole case. It's quite difficult to score a 0. It would mean that you'd gone completely off track in the history and not done the appropriate examination, then managed badly. So it is possible to get a 0, but as I say, if you understand the structure and understand the way that we take you through it, then you won't score 0 in any case, I guarantee you.
Perfect. Thank you very much, Mark. We're just going to stop taking questions now, but if you carry on leaving questions on this Facebook feed or on our Facebook page, Mark and us will try our best to get back to you with the answers quickly.
Fairly shortly.
Yeah. Thank you very much.
Only just got in time from surgery, so so I'm probably going to have something to eat now, and then I'll answer your questions and stuff over the next 24 hours. But you know, genuinely, we anything that we can do to help, we will do.
Perfect. Thank you very much.
Nice, everyone.
Bye.